this is a case of retreatment, Lasik retreatment. This is a female lady, 43 years old, coming for diminution of vision for distance as well as for near, and she reported that the diminution of vision is more at the night time. She had previous laser refractive surgery 12 years ago. She's not sure about the procedure, whether it was Lasik or surface ablation. She has no previous refractive surgery record, and examination showed the cornea is clear, there is no haze, no abnormality could be detected in the anterior and posterior segment. The corrected distant visual acuity in both eyes is 1, and she can reach 1 with addition of 3/4 of the diopter. You can see the refraction here in the right side of the screen. She has almost 1 diopter of astigmatism in both eyes. Most probably this is the reason of her dissatisfaction after the Lasik, 12 years after the Lasik. And she asked for solution for this case. You can see this is the corneal topography or tomography, let's say, and you can see there is no abnormalities regards the anterior or posterior elevation maps on the right as well as on the left side, like the mentioned Dr. Tariq Nagar. So we can exclude now the ectasia as a reason for diminution of vision in this case. And you can see that here in central flattening, the anterior surface of the right eye as well as on the left side here, you can see that the astigmatism is almost topographic astigmatism, because the axis here of the refractive astigmatism matches the axis with the topographic of the astigmatism on the right side as well as on the left side. You can see this is the astigmatism on the left side, and this is the topographic astigmatism on the left side. So most probably this patient suffers from low order aberrations due to some sort of regression after 12 years after her previous surgery, whatever it was Lasik or it was surface ablation. We did OCT on the anterior surface to confirm if this is some sort of corneal cut has been done or not, and we didn't found any Lasik flap here, so we concluded that this is case of surface ablation had been done 12 years ago. So my decision in this case is to do another cut with the femto Lasik. So I did femto Lasik both eyes with blended vision. It's not mono vision or micro monovision I've just mentioned, and her left eye was the dominant eye. The left eye we target 0, and the right eye we target minus 0.75, just some sort of micro monovision, and we assigned the topography guided Lasik ablation to correct the low order abrasion as well as trying to smoothen somehow the surface of the cornea to improve the visual quality. And you can see here, this was my plan at the time of the surgery. This is the left eye, this is the dominant eye, we target here 0, and this is the right eye, I'm target here 0.75 of myopia. And this is the Lasik flap. Everything was fine for the right and for the left side. And this is the topography guided ablation profile for the right side. You can see this is the topography guided ablation profile, and to correct some sort of let's say coma on the eye. This is the left eye and this is the right side here. You can see some sort of coma. We can correct this coma with the topography guided ablation. And this is something already I have learned from Arthur, and how to target myopia and how to target emmetropia in these cases. For this, the left side, we did just couldn't get clear TCAT maps, so we just went for the custom Q ablation profile, not the topography guided, because we didn't get a good quality TCAT photos. So we just straight ahead went for the custom Q ablation to correct the astigmatism of this patient. And after 2 weeks, the patient was unhappy. She is not satisfied with her distant vision. She reported improvement in her near vision because of the myopia induced in the right side. But surprisingly, the left side now shooted to hyperopia. And I was waiting for regression at that time. So she would come back after 2 months, and still there is hyperopia in the left side and the myopia in the right side. She is still pleased at that time with the reading ability on the right side, but she is completely dissatisfied with the distant vision in general, obviously because of the dominant eye, which is the left side in her case, is suffering of a significant amount of hyperopia. So what to do in this case? I ordered again for topography, and you can see here There is nothing wrong. We could increase the ablation profile here. The ablation zone now is much larger than before. So we covered all the pupillary area on the right side as well as in the left side. There is nothing wrong. And we asked for epithelial mapping to see if there is some sort of epithelial hyperplasia, maybe responsible for this regression. But as you can see, this is the epithelium of the right side, and this is the epithelium of the left side. They are typically normal and typically equal on each side. So there is nothing wrong with the epithelium in this case in particular. So most probably, I believe that this regression or this is induced hyperopia maybe because of the relaxation of accommodation this patient experienced after the myopia in the right side. Probably the myopia in the right side causes some relaxation of accommodation that the patient used or utilized for the distant vision, revealing some latent hyperopia in the left side. So what to do in this case? Of course, I get the patient again for the second time for another re-enhancement for the left side, but I could just remove the flap or lift the flap and do the laser, but I didn't do so. I just went for direct surface ablation. Why? Because as you can see, this is the ablation zone to correct this hyperopic residual hyperopia for the left eye. You can see that the ablation zone is 8.9 millimeter and the diameter of the femto-Lasik flap was 8.9 millimeter. So this will carry a high risk of epithelial ingrowth because the laser shots will almost on the edge of the flap, and this of course will carry high risk for epithelial ingrowth. So that's why I resorted in this case to surface ablation. And as you know, the epithelial ingrowth increased with the retreatment and increased with the hyperopic ablation much more compared to myopic ablation profiles. So that's why I did the surface ablation, transepithelial PRK, and finally the patient is satisfied. You can see this is the final reflection of this patient, myopia of minus 0.75 in the right side and almost immetrope in the left side. Now she's able to read and text on the mobile phone without reading glasses, and her vision binocularly is 1.2, just one. And she's pleased with the quality of vision at night time. So the key points here, you have to understand that the patient complaint in cases of retreatment or re-enhancement, because you have to differentiate if the complaint is directly related to visual quality, some sort of coma, trefoil, or spherical aberration, or the acuity, which is the low order aberration, some sort of myopia, astigmatism, or hyperopia, or sometimes the patient simply complain of presbyopia and the patient does not know that at the age of 40, the patient might use some reading spectacles. And simply, you can just tell the patient everything is fine. You can use the reading spectacle and the patient is fine with that. Some patients are highly demanding patients. They ask for solution for this presbyopia, and we can, of course, resort to the blended vision as Arthur mentioned. The other key points here, I would like to stress that the surgical planning is dependent on the chief complaint, whether it's related to the visual quality. So we have to use some sort of topography or wavefront guided ablation profiles. Of course, the refractive history, if the patient has done surface ablation or just LASIK, you have to do either the flap lifting or just another side cut or just surface ablation. What about the flap thickness of the hair primary surgery or the previous surgery? And what about the epithelial mapping? If there is any hyperplasia or atrophy or thinning of the epithelium in some areas of the cornea, and of course the refractive error. So all these factors will contribute to the surgical planning in the surgeon mind for the retreatment and the enhancement. So my systematic approach in this case is, first of all, you have to rule out ectasia by asking for the topography and tomography to rule out ectasia, and then we can order for epithelial mapping to see if there is something wrong with the epithelium, and then we can discuss with the patient about the complaint and trying to speculate the complaint comes from either visual quality or visual acuity, either the low order aberration or higher order aberration or just presbyopia. And I don't rush for surgery. In these cases, I prescribe a pair of glasses or just one glass for the patient. Tell the patient, try to live with these glasses for just a couple of weeks and come back again, see everything, how things is going on. If things is going on fine with the patient, so the patient can still keep his glasses or hair glasses and stick with the glasses, and that there is nothing wrong, and just put on the glasses whenever needed, and that's it. And if the patient is still unsatisfied or dissatisfied because of the quality of vision with the glasses is not met by the patient demands, or the patient does not simply want to put on glasses. So in this case, I will go for the surgery. And of course, surgical planning depends upon different factors, as I mentioned in the previous slide. So thank you for your attention.